Pertuzumab, the therapy in the HER2 positive breast cancer, is a well-tested molecule IV. So along with the trastuzumab combinations, everyone were used to this. But recently, this new product is came in the market. It is Parjeta plus, sorry, it's a phase go. That is the subcutaneous formulation. This trastuzumab plus pertuzumab combinations, fixed vial combinations, is a loading dose followed by maintenance in a subcutaneous formulary. And it was tested in the clinical trials, phase 1, phase 2, phase 3 subsequent onwards, with pharmacokinetics and pharmacodynamics, and they have showed the clinical efficacy response as well as side effect and compliance is almost similar with our IV formulations. All of us know the neoadjuvant, adjuvant and metastatic. We have Neosphere study, we have affinity trial, we have Cleopatra, where there is a benefit of and trifena all has shows the maximum patch shear benefit in terms of when we are used dual HER2 blockade. So dual HER2 blockade therapy is a where addition of trastuzumab plus pertuzumab along with the chemo backbone, it definitely improves the patch shear rate from 30% to 40% to 60%. And we have the Cleopatra in metastatic setting, where addition of trastuzumab plus pertuzumab along with the chemo backbone have significantly increased in the median PFS, as well as the median OS was significantly increased to 56 months compared to the only trastuzumab plus chemo arm. So this is a HER2 positive advanced early breast cancer study, where pertuzumab, trastuzumab plus chemotherapy is neoadjuvant standard of care as adjuvant standard of care in patient with without residual disease after surgery. If we look at these flow chart, all of us know patient with the HER2 positive early breast cancer in neoadjuvant settings, if we give triple drug with trastuzumab, pertuzumab plus chemotherapy, if they had a patch shear, we just continue the trastuzumab, pertuzumab, and if there is a residual disease, definitely we have to switch over to the TDM1 in the adjuvant settings as the latest evidence. So in the residual, in view of patch shear, we have to continue 18 cycles of trastuzumab, pertuzumab combinations. If residual disease, 14 cycle TDM1. And now the concept of IV infusion of pertuzumab plus trastuzumab is well established, but can present challenges into patient and healthcare systems, because all of us know IV formulation, there is a long infusion observation, there is a chance of hypersensitivity reaction, and there is repeated pricking due to accessibility of the venous access. These are the if patient is in port or PICC line, they needs regular flushing and these kind of things. So it is necessary for is a very challenge in our practice of IV combinations of these two drugs. For that reason, the subcutaneous formulations came into the picture, and Phase-Go is the first formulation in oncology to combine two mAbs, pertuzumab, trastuzumab, in one vial for subcutaneous injection. So contains the same antibodies as approved for IV pertuzumab plus trastuzumab, and has a different role of administration, different route of administration, is formulated with the recombinant human hyaluronidase to allow the subcutaneous administration of the higher drug volumes, 15 ml loading dose followed by 10 ml maintenance dose, and is a ready to use fixed dose formulation administered by subcutaneous injection in the thigh over approximately 5 to 8 minutes. So mechanism of action of pertuzumab and trastuzumab fixed dose combination is a subcutaneous use. Pertuzumab plus trastuzumab is a fixed dose combination subcutaneous preparation, that is a two monoclonal antibody combined, that is a with a human hyaluronidase is a basically is a carrier molecule that is mainly for the delivery of the drug, because hyaluronidase is an elastin molecule with a hyaluronidase enzyme that actually allows the subcutaneous delivery of the drug in the larger drug volumes. When the injection is given in the subcutaneous preparation, all of us know the anatomy of subcutaneous, there is a hyaline fibers, and these hyaluronidase enzyme that degrades the hyaline fibers, and the better penetration of the drug in a larger volume and a better surface area and absorb quickly into the bloodstream. So, hyaluronidase increases the permeability of the subcutaneous tissue by depolymerizing hyaluronone based on the preclinical studies. The effect of hyaluronidase are reversible, and permeability of the subcutaneous tissue is restored within 24 to 48 hours. So, if we see this pictorial diagram, we can understand the subcutaneous layer contains a matrix of hyaluronone fibers and the collagen fiber, our normal anatomy of the skin, and which limits the subcutaneous administration of the volume less than 1 ml. But the addition of these recombinant hyaluronase molecule, that is a carrier in the phase go, which is given subcutaneously, it degrades these elastin fibers and the collagen fibers, and it dissolves, and better the drug is get better permeability and quick absorption from the subcutaneous into the circulations. And the degradation of these hyaluronone molecules results in a temporary increase in the local surface area, rather dispersion, more wide area, and enable larger volume of the fluids. And after subcutaneous administration, the reformulation of the normal anatomical structure occurs quickly within 48 hours, and the drug delivery is occurred already. So, these are the basic of pharmacodynamics and pharmacokinetics models where phase go preparations came into the picture, and it was tested in the preclinical and clinical studies. So, this allowed these molecules of subcutaneous administration of a larger volume, larger than 1 ml. This is the pictorial diagram. So, does now the dose, what is in phase go preparation, if we see the loading dose and maintenance dose of trastuzumab, pertuzumab in larger, higher, quite higher rather than the normal we are using. So, it is also tested in the PKPD study. I am going into these details. Yeah. So, these are the phase go clinical development program, where first it was tested in phase 1B studies. The recommended dose was 1200 milligram loading and 600 milligram trastuzumab dose is loading, followed by 600 trastuzumab pertuzumab maintenance. And if we see this Fedrixia trial, it is ongoing, and the latest one, it was a phase 3 and phase 2 study where they primarily analyze the PKPD value and the drug concentration value after subcutaneous administration of phase go. So, in this study, the phase 1B dose escalating trial, they used to selected the dose of pertuzumab of phase go, and initially it was several cohorts. If we see this 420 mg, now it is 400, is 600, 1000, 1200, and there are several permutation combination are used in a dose escalation trial, and the all cohort ultimately the efficacy on the PKPD testing was done and shows 1000, 1200 and 600 was the standard, is can become the standard with the clinical equivalent clinical efficacy along with the comparison with the IV preparations. If we see the PK and dose finding, the selected loading dose of 1000, 1200 milligram pertuzumab subcutaneous and a 600 milligram pertuzumab as a maintenance dose to be used, and PK data is healthy male volunteers and patients with early breast cancer predicted those with result in equivalent pertuzumab serum exposure to Diaz Perjeta 484 and 420 mg respectively. So, that is tested in the clinical study. The dose finding process used to find the subcutaneous dose of pertuzumab was similar to those used successfully in the both Herceptin subcutaneous and MabThera subcutaneous study. Safety, there is no safety signals still reported and observed in this study in the pertuzumab arm, and the PK and safety result supported the further development of phase go. So, the Fedrixia trial, it is phase 3 non-inferiority study assessing the PK efficacy and safety of the fixed dose combination versus subcutaneous versus IV. There was a head-on comparison where the investigator choice was given in the IV formulation that are commonly used along with the paclitaxel or docetaxel backbone with the IV 3 weekly preparation, and the study arm was the fixed dose combination with these two formulation along with the chemo backbone in the 3 weekly. So, after surgery neoadjuvant, then continuation of the adjuvant with the maintenance and the follow up. The primary endpoint of this study was the pre-dose cycle 7 serum concentration of this drug before cycle 8, and the secondary endpoints were the non-inferiority of the serum concentration, safety and others. If we see these primary endpoints, PK endpoints is a very key focus of this study, and these are almost equal in IV versus subcutaneous preparation. At the concentration of the drug at the after cycle 7, it is almost same along with the IV preparations. So, it is tested. If we see this primary endpoint, serum concentration is 88.7% versus 72.4%, and the secondary endpoint was in the PK population was almost similar. So, we can say that these other secondary endpoints of the pathological complete response, CR rate is almost equally efficacious in phase go versus IV preparations. Regarding the adverse effect, any grade of adverse effect is almost quite similar. It was 99% versus 100%. Grade 3 and more adverse reaction is 52% versus 48%. Any serious adverse effects is negligible, 16 versus 17. Discontinuation after randomization is 10% versus 6.9%. So, it is almost similar in terms of efficacy. The alopecia, nausea, diarrhea, anemia, asthenia, these are the common side effects that we seen in the IV preparation was almost same in the subcutaneous fixed dose preparation. If we see this incidence of adverse effect of interest, including cardiac dysfunction, hypersensitivity reaction, that is almost similar. The cardiac dysfunction is 16% versus 16%. Although the dose used in these fixed dose preparation is quite higher, but still the cardiac incidence is almost similar in both of these studies. There is no meaningful difference in cardiac safety between the treatment arms. Fixed dose phase go showed non-inferiority PK value versus IV preparation in compared to the efficacy and safety, and these are showed to be in terms of secondary endpoints with the safety and tumor pathological response rate is almost identical to the IV preparations. So, do patients prefer fixed dose subcutaneous rather than the IV? Definitely, it is also tested in another study, in a phase 2 study where patient preference is given in IV versus subcutaneous formulation. Obviously, the patient goes in the IV, obviously patient choice would be better in the subcutaneous because of the easy administration of the drug. So, this study is preferred subcutaneous versus IV. The almost if we see this 88% patient prefer subcutaneous versus 13% prefer IV formulations. And the preference of subcutaneous was very and fairly strong for majority of the patient. 93% of these patients prefer subcutaneous preparation rather than the IV. Because of the less time in the clinic, more comfortable using the administration, and around 87% choose fixed dose subcutaneous to continue the treatment. So, it is also tested in this study and they are very satisfied scoring was there, and treatment has no impact on patient speaking time is almost 85% versus 79%, and most of these patients are more higher time to talk their treatment regarding these subcutaneous fixed dose preparations. This study, majority of healthcare professionals felt that switching from the IV to subcutaneous would have time source savings and resource savings also. So, 88% of these healthcare professionals thought that the subcutaneous preparation is very quick to administer and easy to administer, and there is less resources used because the staff nurse, the daycare sister, everything will be the less, and the 77% are agree and strongly agree the use of subcutaneous preparations. So, the AE rates is almost similar. I am not going into the details because the diarrhea, fatigue, hot flush, injection site reaction, these are almost similar in this trial. So, the main reason for fixed dose preparation in this study, the less time, more comfortable drug administration, more patients are very satisfied in these preparations, and healthcare professionals also they prefer subcutaneous preparation which is tested in this study. Safety concern, definitely it is well tolerated and with safety profile, and no new safety signals is still observed in this study. So, what are the practical consideration for using fixed dose combination subcutaneous in the real world? That is the questions one should keep in the mind, because the administering this pertuzumab trastuzumab fixed dose subcutaneous, we have to first train our daycare sister how to give it, and minimum time for observation, and these subcutaneous preparation should be given in the thigh and not in the umbilicus or not in the abdomen. This is most common. Our daycare sister and healthcare professionals should be trained before giving this drug, and after administration subcutaneously we have to wait for some times because of any adverse reaction like hypersensitivity or any another emergent adverse effects is occur or not. This is important. And another important thing is, do not split the dose between the two syringe or between the two sites of administration, even with a very slim patient. These two things are basically we have to keep in mind, and we have to train our sister who are giving this medicine. So, administering pertuzumab trastuzumab fixed dose, the injection, it is clearly given in this diagram, and what is the time limit? We have to watch for the 5 to 10 minutes minimum after giving this injection, and 30 minutes observation is recommended as per the literature review says. And after maintenance dose, the patient should be observed minimum of 15 minutes. So, for the loading dose 30 minutes observation is required, and for the maintenance subsequent dosing 15 minutes observation is fair enough. So, practical thing, aside the hospital space, administration of pertuzumab trastuzumab subcutaneous area, depending on the hospital outpatient setting, dose can be administered on a dedicated date. Having a single room for administration, observation gives patient enough for physical privacy, and but the enables to talk them more freely about the physical and psychological changes. If the drug is administered in the chemotherapy day unit, curtains or other shades are required to ensure patient privacy. A blanket on top of the patient's lower abdomen and pelvis may make them feel less exposed. To ensure patient comfort during administration, a bed or recycling chair is required. Nurses should have a comfortable chair and removable drug table to ensure quality and safety of administration. What could PHESGO mean for patient and healthcare professionals? Definitely, these are the short conclusions. Shorter administration 5 to 8 minutes and observation period of 15 to 13 minutes of PHESGO reduces the burden on patient cares and the providers. PHESGO has less invasive administration because it is single subcutaneous administration in 5 to 10 minutes injection. The freely patients can from burden of the IV related issues like availability of the daycare slots, timing, their pain, needle pricking, flushing of the port or intervening catheters, these kind of things is automatically come down. Fixed dose formulation may help reduce risk of dosing errors, reduce drug wastage, increase availability of nursing and privacy staff for the other risks and hazards, reduces time required for drug penetration and administration of PHESGO versus IV, and no new safety signals still observed from switching to IV to subcutaneous preparation as vice versa. So, overall summary, PHESGO is the first formulary in oncology to combine two monoclonal antibodies in one vial subcutaneous injections that offers the faster and less invasive methods of administration compared to the IV formulations. PHESGO had cycle 7 serum concentration that was equal to the IV preparations are tested in the clinical trials, and whenever switching formulation is also, and tumor pathological complete response rate is quite identical along with in comparison to the IV preparation in the intention to treat population, but were not impacted by the body mass index. Majority of the patient has IV preparations versus subcutaneous preparation. That regardless, they opted definitely for the subcutaneous one, and the sequencing, and they felt subcutaneous has no impact on patients, and when asking and speaking them for the time, and as well as it is very safe, and they are well accepted among the healthcare professionals, those who are administered in this drug. Phesgo is now FDA and EMA approved for the same indication as for the IV preparations in advanced breast cancer, early breast cancer, and metastatic breast cancer. Those are HER2 positive disease. So, one important thing apart from these clinical studies, we have a more real world evidence, needs real world data to generate our own real world practical experience and the safety profile of the Phesgo to implement and in the common practice, and in our future we also see what is going on in comparison to the in terms of OS and overall survival and the PFS when compared with the IV preparations. That's the important things should be kept in mind. So, thank you for giving me this time.